Hi, this is Barbara Gay, Leading Ages Director of Governmental Affairs. Today I want to discuss the public policy principles that our Policy Congress developed and issued last year, which have been the basis for our advocacy on Capitol Hill. We have our own initiatives, then we also have to respond to other activities in Congress that affect aging services providers. So what we've been following are federal budget and spending issues, Medicare and Medicaid, senior housing, long-term services and supports financing, and tax reform. The first of the public policy principles that our Congress issued were on the federal budget. The Congress said both parties, Democrats and Republicans, need to take a fair, balanced, and responsible approach to deficit reduction. They said that Congress should avoid across-the-board spending cuts or government shutdowns that are damaging to our members' ability to provide services to frail elders. And we said any efforts to reduce the federal budget deficit should spare those who are least able to provide for themselves in terms of food, shelter, and health care. Most recently, Congress reached a deal on the fiscal 2014 budget. This was an accomplishment given that fiscal 2014 had already begun 2 months earlier. Congress passed the deal in December 2013. What we liked about the deal was that it did allow for some increase in spending on what are called non-defense discretionary programs. These are programs like senior housing, like home and community-based services under the Older Americans Act, both of which are subject to the annual spending process appropriations. Medicare and Medicaid are not part of the annual spending process, but there were provisions in the budget deal to extend the 2% sequestration on Medicare payments to skilled nursing facilities and home health agencies for another 2 years, which will be through 2023. Now, following the budget deal, Congress was able then to pass a spending bill. They previously had been unable to pass any of the appropriations bills that cover the current fiscal year. The omnibus spending bill was signed into law January 17th. It restored funding for senior housing and Older Americans Act programs that had been cut under sequestration last spring in 2013. We did get some money that could go to a Housing with Services demonstration program. This is something that we think is very important. It points us toward the future of aging services, and it's something that we're going to be working with HUD on to get this set up and get it going. What concerns us is that the Section 8 funding provided under the omnibus spending bill may not be sufficient to fully cover all rental assistance contracts. We've had experience in the past with short funding of these contracts, and it's been very difficult for our housing members to maintain their operations when they have to take money out of reserves for their routine operating expenses. So this is something that we're going to have to work on this year, is to make sure that rental assistance contracts do get the funding that they require. The omnibus spending bill did not affect Medicare and Medicaid, but there are other measures that may involve those two programs. In terms of Medicare and Medicaid, our Public Policy Congress said that both programs need to pay adequately for the services they cover. In many states, Medicaid does not adequately fund nursing home care and home and community-based services. And what typically happens is that our members have to cross-subsidize, essentially, use Medicare funding to cover the shortfall that they experience from Medicaid. Our Public Policy Congress said that is wrong. Both programs need to take valid costs into account in setting reimbursement rates. And so the fair payment standard should apply to both programs, and especially because we're seeing now these two streams of funding combined for people who are eligible for both Medicare and Medicaid. So the current issues affecting these two programs primarily affect Medicare. We are not seeing too much activity right now at the federal level on Medicaid. But on Medicare, we've been watching out for what might happen under the federal debt ceiling. We're looking at what might happen as Congress attempts to fix the physician payment formula known as SGR, or the Sustainable Growth Rate. And we also have a very specific issue going with observation days. The federal debt ceiling has just been raised, and we kind of dodged a bullet on this issue. The statutory limit had been $16.7 trillion, and the federal government was hitting that limit in terms of its routine borrowing to cover operating costs for the entire federal government. Now, when Congress has to raise this limit, typically what happens is there is a lot of concern, a lot of discussion about the need to reduce the federal budget deficit, which is something I think we all agree about. But that a lot of times also entails discussing the mandatory spending programs that include Medicare and Medicaid. So we typically pay a lot of attention to what Congress is saying about what needs to happen in order for the debt ceiling to be raised. This time, we dodged a bullet. This time, the House and the Senate both passed a clean version of the debt ceiling increase. They simply increased it without making changes in any federal programs. And that increase is good through March of 2015. So again, next year we'll have to be watching out for what might happen with a debt ceiling increase. Now, because Medicare and Medicaid combined constitute about 1/6 of all federal spending every year, they do tend to have a big target painted on them when Congress looks at deficit reduction. What we're saying is we understand that the budget deficit does need to come down. However, our field has taken a lot of hits recently in terms of Medicare reimbursement, and we have a little list. Under the Affordable Care Act, skilled nursing facilities, home health providers are getting market basket updates below the actual increase in the market basket. In August 2011, skilled nursing facilities got an 11% cut. In February 2012, there was a cut in skilled nursing facility reimbursement for bad debt. Last year, we had the 2% cut in reimbursement to all healthcare providers, which includes skilled nursing facilities and home health reimbursement. And I just would say a word about this 2% sequestration. It has become kind of a little piggy bank that Congress is going to when they need to offset the costs of other things they want to do. For example, Congress just passed legislation to restore the full cost of living adjustment in pensions for younger military retirees, those under the age of 65. And in order to offset the cost of restoring the COLA for the military retirees, Congress extended sequestration for healthcare providers for another year through 2024. So on the one hand, we kind of resent being a piggy bank. On the other hand, this is a future cut, and they're not doing anything immediately to make more cuts in our reimbursement. So it's kind of a good-bad thing. We do oppose any more across-the-board cuts. What we've said to Congress is there are ways that you could revise the current reimbursement system for skilled nursing facilities to better reimburse the kinds of complex care that leading age members tend to provide, and kind of de-emphasize some of the higher drug levels that we think may be overcompensated. And we think that that would be a valid way to to revise our payment system. In addition, we look at the reductions that have been made as a result of the Affordable Care Act. They actually are taking the trajectory of Medicare spending in the right direction. The growth of Medicare spending per beneficiary actually is falling, and so it's growing at a less rapid rate than had been the case before the Affordable Care Act. So we think that the many provisions of the Affordable Care Act that set out to reform the healthcare delivery system and the healthcare payment system are having a beneficial effect that should be taken into consideration when Congress looks at deficit reduction. Okay, so back in 1997, Congress passed the sustainable growth rate. Congress was concerned about the rapid growth of Medicare spending, and they established the SGR as a means of bringing down the growth of Medicare spending. And this formula, adopted in 1997, is deeply flawed. For the last 10 years or so, if it had been allowed to go into effect, it would have meant severe and growing payment cuts for doctors. So to prevent those cuts and to prevent doctors from leaving the Medicare program, Congress has done annual payment fixes, the so-called doc fix, that have put patches on the payment system every year to keep reimbursement levels fairly steady. Now, Congress understands that this is not a great way to do policy, not a great way to do payment systems. Both the House and the Senate developed legislation to permanently fix the physician payment formula, and they now have reached consensus on a bill. In the House, it's H.R. 4015, and they extended the current patch through the end of March. What this means is that before the end of March, Congress either has to do another temporary patch or they need to pass the permanent doc fix. What does this mean for us? We have an issue that has been added to the temporary patches every year because also in 1997, Congress slapped a absolute dollar limit on Medicare coverage of outpatient therapies. And these limits have been increased according to the rate of inflation every year. However, the limits themselves are not adequate for the amount of therapy that Medicare beneficiaries need in the event they've had a stroke, a broken hip, any other serious condition, injury, healthcare concern. And Congress recognized early on that the therapy caps were a mistake. So every year, when they have done the doc fix, they've attached provisions to either set a moratorium on the therapy caps or, more recently, they've developed a medical review system and an exceptions process that enables people who have a need for therapy that's medically necessary to be able to get it without the caps having an effect. We're concerned that if Congress does a permanent doc fix, they need to include a permanent therapy cap fix as well. Otherwise, in the future, we won't have a vehicle for being able to get the therapy problem addressed. Our other concern is we don't want post-acute care to be the pay for, the offset for the cost of fixing the physician payment formula. Right at this moment, the consensus bill that is in the House and Senate does not have provisions either for the therapy caps and other what are called extenders, other kind of very specific changes in Medicare that Congress has enacted every year. So we're not seeing the extenders in the current bill, nor are we seeing provisions for a pay-for. And so we are still urging Congress to include the therapy caps fix and not to make us the pay-for because of the reimbursement cuts that we've already discussed. We do expect action on this bill within the very near future because, as I said, Congress has to figure this out before the end of March. Many leading age members have told us about residents or potential residents who have been kept in the hospital under what's called observation for extended periods. This means that they are not inpatients. They are being kept in the hospital as outpatients, which means in turn that their stay is not meeting the 3-day stay requirement for Medicare coverage of a subsequent stay in a skilled nursing facility. So when the beneficiary leaves the hospital, most of the time having no idea that he or she has been an outpatient and hasn't met the 3-day stay requirement, they then find that a stay in a skilled nursing facility is not covered by Medicare. We and other stakeholders are urging Congress to fix this problem. And we are collaborating with a group of over 20 stakeholder organizations that's headed by consumer groups, because of course this becomes ultimately a consumer issue rather than a provider issue. So there is a lot of support for legislation to say that any time spent in a hospital, whether it's under observation, whether it's as an inpatient, any time that a person is in the hospital, that counts toward the 3-day stay requirement. Also that if Medicare beneficiaries leave the hospital after a period of observation, they are to be considered to have been discharged, because that's another issue with not being able to qualify for coverage of post-acute care. We have bipartisan co-sponsorship of this legislation in both the House and the Senate. We have been urging Congress to include this legislation, the fix for observation days, in the larger bill covering the sustainable growth rate. So far they haven't done that, but we're still urging them to. Now, with regard to the 3-day stay requirement, some people have said, well, why don't we just repeal the 3-day stay requirement? That does have other repercussions. There's a bill in the House to repeal it, but it has little chance of passage because it would tend to increase Medicare costs. We already see that integrated systems where the system itself is at risk for all patient costs are already accepted from the 3-day stay rule. We think that CMS can do pilot projects to allow patients to receive skilled medical services in nursing homes, but currently CMS lacks the infrastructure to be able to monitor the potential churning of patients between long stay and skilled care levels within a nursing home. That would tend to increase Medicare costs, and we think that's why Congress is not going to completely eliminate this requirement. Turning to tax issues, our policy Congress said that the not-for-profit difference is really critical. Not-for-profits are guardians of values, of crucibles of innovation, cultivators of volunteerism, and stewards of the public interest. The policy Congress said tax incentives for charitable giving support our mission, and these incentives must be preserved for taxpayers at all income levels. This became an issue last year when both houses up on Capitol Hill began to look at comprehensive tax reform. Larry Minnick testified at a committee hearing on the House side on the need to preserve tax benefits for not-for-profit organizations. And at that hearing, we heard a wide range of views from members of Congress as to what they considered tax reform to be. Some members of Congress thought that the tax system should be made more fair. They noted, for example, that homeowners can deduct a portion of their housing costs, whereas renters can't. They looked at the total ball of tax benefits and how much people at upper income levels benefit from that versus people at lower income levels. Other members of Congress wanted to cut tax rates and eliminate a lot of the complications with the tax code. Other members of Congress had particular concerns about corporate taxes, and so a number of task forces, work groups were set up on both sides of the Hill. House and Senate committee chairs conducted a national tour last August during the recess to gather public comment on tax reform and see what Americans think needs to happen to our tax system. And last year we really thought that we would be seeing tax reform legislation. But a couple of things happened. First of all, the House and the Senate leadership never came to a consensus on the basic question of how much revenue the tax code should actually raise. That was kind of a bottom line starting point from where tax reform would jump off, and that hasn't been arrived at as yet. Another thing that happened was that Senator Baucus from Montana was the leader of the tax reform effort on the Senate side. He has left the Senate now. He has become the ambassador to China, and his successor, Senator Wyden from Oregon, is kind of stepping into a number of different issues and has not yet made clear what his intentions are for tax reform. So we think that tax reform legislation affecting not-for-profit organizations is unlikely to happen this year, with a caveat that you can never say never with Congress. The last time they did comprehensive tax reform in 1986, it happened in a lame duck session after the election, and as I recall, it was on a voice vote in the House. So you can never say never, but it looks unlikely at this point. Our concern, the Senate was especially looking at what they call the clean slate approach, where you would take all the tax benefits in the code out and only put back the ones that everybody agreed should be in there. And we were very concerned as to how the deduction for charitable contributions would make out under that approach, as to how tax-exempt status for charitable organizations would make out. We were concerned about tax-exempt financing, bonds issued on behalf of charities. So there were a number of issues that we were really concerned about how they would fare in a clean slate approach. Right now, it's looking as though that's not happening, but we're keeping a very wary eye on what is going on Capitol Hill. Our Public Policy Congress looked at how long-term services and supports are financed. And they said that a financing system must allow for services to be provided in a person-centered way in the setting chosen by the consumer. Our Congress said that personal responsibility should be incentivized while balancing long-term costs and risks of needing services. There's been a lot of debate in the last several years about a better way of financing the services that leading age members provide. Currently, especially in the healthcare area, there's a lot of dependence on Medicaid, which was never intended to be a long-term services and supports financing program, and yet 2/3 of its spending now goes in that direction. So our membership leaders have, since 2004, been looking at financing and trying to figure out a better way. We had class provisions included in the Affordable Care Act. That program was repealed, and in place of class, Congress enacted the Long-Term Care Commission, which was to spend 6 months looking at a number of issues related to long-term services and supports and come up with recommendations. Last year, the Commission held 4 hearings. We participated in them, discussing the need for Congress to look at what happens to middle-income families in particular. We said that upper-income families can generally afford to self-finance long-term services and supports. Lower-income people generally qualify for Medicaid, but it's the people in the middle who need help in planning for their own long-term services and supports needs. We said you have to look at the issue of family caregiving. You have to look at the workforce that's going to be available to provide services to the baby boom generation in particular. Larry Minnick talked about our financing task force and some of the work they have been doing on this issue. Other interests that participated in these hearings represented long-term care insurance, and there was also discussion of what happens with asset transfers, where people who might be able to afford to pay their own long-term services and support costs do various forms of estate planning in order to be able to qualify for Medicaid. And are there further steps that Congress can take to discourage that activity? The Commission duly issued their report within the time frame required. The report discussed a lot of what leading age members already know. It talked about the demographics of aging, it talked about the workforce, it talked about how services currently are provided in silos, and people access services according to how they can be paid for rather than according to what the consumer may actually need. Members of the Commission also discussed costs. Unfortunately, the Commission was unable to reach consensus on recommendations with regard to financing, and they listed alternatives. You could either strengthen private options for paying for long-term services and supports, encouraging more people to buy long-term care insurance, encouraging reverse mortgages, doing more in the way of asset recovery, or you could do a social insurance program with mandatory participation by all Americans and the government paying for long-term services and supports. And they discussed a number of permutations of this. Maybe it would just be catastrophic coverage, backing up whatever the individual had done or so on. So we have this report. The Senate Special Committee on Aging had a hearing in December to continue the conversation. They heard from several of the commissioners. They heard from other long-term services and support stakeholders. And we are going to really work hard with members of Congress to continue to pay attention to this very important issue, which is going to grow in importance as the baby boom generation begins to age into needing long-term services and support. We have had our own member task force looking at this issue, trying to figure out better ways to pay for what we do. And we have our own report called Pathways, which was developed by our task force. Our task force noted the need for greater public awareness. A lot of people still think that Medicare is going to cover long-term services and supports. We talked about the need for more individual responsibility in terms of planning. And the task force laid out 7 different potential approaches to financing long-term services and supports that went anywhere from complete individual responsibility with no governmental involvement to a complete government program that would just take care of everybody. And this is going to be the basis for our continuing conversations with Congress. Most groups, when we have presented pathways, have said, you know, you need an approach that's in the middle. You need to have a combination of social supports with more personal responsibility. So our report is up on our website, and we would encourage your input as to what you think should be the advocacy that we should be doing on this issue. Home and community-based services are a growing trend in long-term services and supports. And our policy Congress said that the Older Americans Act, which provides federal funding for a number of these different initiatives, should be reauthorized. We want to see the addition of a housing with services program because we think this holds a lot of promise for enabling people who need just a little bit of help to be able to remain in their homes, remain in their communities. The Older Americans Act currently is without authorization. It's without legal standing, so to speak. And what happens with programs in that situation is funding is continued for their existing activities, but nothing new can happen with them. And they do run the risk of having their funding severely cut because they don't have legal standing. We also said that funding for Older Americans Act programs must keep pace with the growing population of elders in need of supportive services. For the last several years, OAA programs received a total of $1.7 billion for the whole country. And after sequestration, they were down to approximately $1.3 billion. That's not the direction the funding needs to go when you look at the older population. Older Americans Act programs in particular include nutrition assistance and transportation assistance. Those are two basic services without which people who can't provide for their own needs are going to have to go to a higher level of service if they can't get their needs met. So we feel that it's very important for the funding for Older Americans Act to continue to grow along with the older population. We do have reauthorization bills in both the House and the Senate. Now, our disappointment with this legislation is it doesn't have our particular initiative that we wanted in it. But we still think it's important to support this legislation because all of the aging services related advocacy groups in town each have their own initiative that they want included in the Older Americans Act reauthorization. And the more new things that are included, the harder it is to get the reauthorization bill passed. So we and the other advocacy groups are supporting a clean, plain old vanilla reauthorization in order to get the Older Americans Act back to legal standing and be able to build on it from there. So we are supporting this legislation. We're urging Congress to pass it before the end of this year. And our policy Congress also looked at the issue of quality and how it can be maintained in especially nursing home situations and home health situations. They said that quality enforcement should be premised on person-centered care with standards based on empirical evidence and best practices. We said that the oversight process should focus on excellence, not deficiencies. This is one of the issues we have with the current oversight system under OBRA, is that it's based solely on compliance with a minimal level of quality. There are no incentives there to encourage nursing homes to better provide services, to improve and become excellent. There is just the punishment for failure to comply with minimal standards. And we said that efforts to do pay for performance, which is a current trend in our field, must ensure that the right elements of care are measured and that differences among provider types are recognized, because performance includes not only volume of services but quality of services. And this is what's very important to be taken into account if payment systems are going to be premised on performance. Currently, there's no legislation really on Capitol Hill on these principles, but this is something that we are developing as something to advocate on for the future. So what do we need in all of this? We need you. None of this advocacy happens without the involvement of leading age members. And what you can do is to make it real for policymakers. You know, a lot of times when I've talked to leading age members about doing advocacy, they have expressed concerns about needing to know, specific bill numbers or specific numbers of aging people in the country and so on. And members of Congress can get that any place. There are a number of sources on statistics that they have on tap. What they don't have a lot of times is an awareness of how policies made at the national level affect people who live in their districts, people who work in their districts, organizations that are serving older people in their districts. And so your very important role is to let them know how the policies that they're making here in Washington are going to affect your organizations, your residents, and your staff. One of the most effective ways to do this is to cultivate relationships in your community, in your state, and at the national level. The most effective advocacy that our leading age members have been able to do has been through a continuing relationship that they have cultivated with their leaders at the city level, in the state. State issues in particular include Medicaid reimbursement rates. Our members who remain in touch with their members of Congress have been able to do very effective advocacy at the national level. And all of this is possible. We had a big success story a few years ago where one of our organizations developed relationship, advocated with the city government to move a bus stop to closer to the facility so that the residents would be able to more easily get the bus. That doesn't sound like a big thing, but it made a huge difference to the residents, and it was a great big success in terms of grassroots advocacy. So every chance you get, tell your story, whether it's in your annual report, on your website, in your marketing materials. There's no harm in sending, if you have something significant that happens and you issue a press release, copy your member of Congress on it. There are all kinds of ways. They typically come home to their districts once a month, especially in the House. The House has set up district work periods every month in which the members are home in their districts, in their district offices. And that is an excellent time to go meet with your member of Congress, invite your member of Congress to your organization to be able to meet your residents and staff. Most members of Congress have very little awareness of long-term services and supports. And so all they know is once in a while if they read a horror story in the newspaper, that's all they know about long-term services and supports. We would like to change that picture, and you are the ones who can do it. We have resources on our website where you can find out who your local, state, and national representatives are. We have something called Contact Congress that enables you to send an email directly to your member of Congress, and it gives you background information on the issues on which we're doing advocacy. We would love for you to register for and attend the 2014 Peak Leadership Summit and join us as we do our Capitol Hill visits. I can't tell you how effective that has been in the past in really making members of Congress and their staff aware of the issues that confront aging services providers and their residents every single day. Those visits are enormously useful. So for this information and anything else, you can go to www.leadingage.org. It's been great speaking with you. If you have any questions, my email contact information is on the slide, and we really appreciate hearing from you. Thanks so much.